Hello.
Hello.
So you want to begin?
Yeah, shall we begin? Yeah. Right, we'll start. So I'll start my share screening.
Yes, sir.
Yeah. Good morning, everyone. This is the 27th portion of our challenging case discussion. As usual, we'll start with the short case first, then go to the real challenging problems. Now, this is the story of a 56-year-old man who noticed weakness of left leg and difficulty in walking 4 days after a febrile illness. After the fever episode, he went to the bathroom to take a shower in the sitting position. When he tried to get up, he noticed inversion of his left foot and difficulty in walking and needed support for walking. He became better next day. The patient was seen on the next day, second day. This is the video of the patient. I'll concentrate only on the oral planning, everything and abdominal pressure for the back.
Okay.
Come to
കാല് പൊക്കിക്ക് പാദം പൊക്കിക്ക് പൊക്കി പിടിക്കും
osmosis and norm.
പൊക്കി പിടിച്ചോണേ കയറി കിടക്ക് കുറച്ച് കയറി കിടക്ക് മതി 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 കളഞ്ഞേരവേ ഈ പാദം മുകളിലോട്ട് വരട്ടെ മുകളിലോട്ട് വരട്ടെ ചള്ള വരൽ പൊക്കി പിടിക്ക് ഇതും പൊക്കി പിടി മുകളിലോട്ട് പിടി ബലത്തിൽ പിടിക്ക് ആ ഇനി ഈ 10 ഇങ്ങോട്ട് എടുത്തേ ഇങ്ങോട്ട് എടുക്കാൻ പറ്റും നോക്ക് വരുന്നില്ല ഇങ്ങോട്ട് എടുക്കാൻ നോക്ക് ഇങ്ങനെ ഈ കാല് ഇങ്ങനെ അതേപോലെ ഈ കാല് ഇങ്ങോട്ട് പിടിക്കണം പിടിച്ചോ പിന്നെ പിടിച്ചോ കീഴോട്ട് മടക്കി പിടിച്ചോ പിടിച്ചോ ഇതും പിടിച്ചോ മടക്കിപ്പിടി
reflexes, knee jerks were normal. And knee jerks are also normal. Plantar was mute on the left side, flexor on the right side. Sensations normal. So these are the findings. This is the gait of the patient.
തിരിച്ചു വാ ഇനി നടന്നോ ശരി.
Okay, what is the diagnosis? Anyone can unmute and tell. Want the findings once again? He has got, you know the story when he was we're taking a bath in the sitting position. When he got up, he noticed his foot was going inverted. Examination, he had dorsiflexion weakness on the left foot. EHL was weak, plantar flexure was weak to some extent, and flexor pollicis longus was also weak. Ankle jerk were normal, sensitive, no sensitive nothing. Anyone would like to voice out what the opinion? Am I audible to you? Hello, am I audible? Nancy?
Sir, good morning, sir.
Good morning. Am I audible to you?
Yes, sir.
Yeah. If you can voice out your opinion, what it is?
I'd like to think of a cortical foot drop here, sir.
Okay, very good. Why do you think why can't be a sciatic nerve palsy because of the pressure palsy? You were sitting there for some time and got
one is the history. It seems a very hyperacute history, sir. And second thing is when he walks, there is no high stepping gait. Usually when there is a nerve palsy lower down, we usually get a high stepping gait or only in a cortical foot drop when there is proximal weakness coexistent, we get a gait like this, where there is more of a dragging gait.
Okay, perfect. I think your observation is 100% correct. And one more point is that even though your plantar flexion is weak, angle jack was preserved. And the plantar was flexor on the right side, left side is nude. These are additional points, but the most important points is what you have already said. That's the hyperacute can occur in pressure palsy also. That's not against. Only thing is the gait was not showing a classical foot drop gait. So the gait abnormality and the preserved angle jack and the indefinite plantar, whereas on the flexor on the right side are points favoring a cortical lesion. So these are the things again already mentioned. So this is the MRI of the patient showing an infarct in the antesuballatid territory. It's a cortical foot drop. So just to remind you that sometimes a cortical foot drop, the weakness may be in the distribution of the converoidal nerve. May not be affecting the sciatic nerve distribution. That means may be confined only to the dorsiflex of the foot, and you have to keep the possibility in mind. Okay. So with that, we'll go to the next case now. Shall I go to the next case? Okay. He is a story of a 77-year-old man. He is an old case of bipolar disorder on lithium for the last 25 years. He has presented complaints of walking difficulty for the last 2 years, mainly in the form of slowness in walking. No history of any tremor of the legs. 1 year later, he noticed difficulty in getting up from squatting position and difficulty in climbing up and down the stairs. Along with this, he also noticed paresthesia and numbness over both feet, which ascended up to both knees for the last 1 year. He also noticed difficulty in putting footwear into the chapels. The walking difficulty increased progressively over the next 6 months, and he started using walking aid for the last 4 months. For the last 6 months, he noticed difficulty in taking bolus of food with hands, and noticed dropping of objects from his hands, and difficulty in buttoning the shirt for the last 6 months. No bowel or bladder problem, presently admitted for worsening of the symptoms over the last 2 weeks. So I think reiterate this once again. Bipolar disorder treatment, compared to 2 years slowness in walking. 1 year later, noticed difficulty in getting up squatting position, difficulty in climbing up from the stairs. Along with that, noticed paresthesia of the feet, which ascended up to both the knee. Walking difficulty increased progressively, requiring support for the last four months. I also noticed weakness of the upper limb in the form of taking football and bolus of food with the hand and dropping of objects from the hands. These are the story. And on examination, tone was normal in upper and lower limb. There is wasting of the small muscles of the both hands, which you can see there. Wasted. Power proximal muscles were normal. Wrist extensions was normal. Elbow extensions were normal. Wrist extension was weak on the right side.
That is weak.
Also weak on the left side, but more. Finger extensions was weak bilaterally. But distinctly more weakness on the right side. So you cannot persuade the finger extensions. Extensor pollicis longus was also weak on the right side. Also weak to an extent on the left side. Flexes of the fingers are quite normal. Extensor pollicis longus is also good power. Over the flexor pollicis brevis was weak.
That is weak. That is flexor pollicis brevis.
All the inputs were weak bilaterally.
ഇതിങ്ങോട്ട് തള്ളിക്കേ തള്ളി ഇങ്ങോട്ട് തള്ളാൻ നോക്കിക്കേ
And the introsive were weak, as well as the performance senses positive bilateral. So this is upper limb finding. If come to the lower limb, tone was like normal in both lower limb. The rest was positive.
വിട്ടോ Normally you can go
low limb
not
power.
increased. Say ഇവിടെ
It's about
ഇങ്ങനെ പൊക്കി പിടിക്കാൻ ശ്രമിക്കണം.
both
പൊക്കി
lower
പിടിക്കാൻ
the weak,
ശ്രമിക്കണേ.
both functionally
പിടിച്ച്
and
നിർത്തണം.
both functionally.
അച്ഛൻ ശ്രമിക്കും
It's about
മാക്സിമം.
just be
ബാക്കിയെല്ലാം
power on
നോക്കിക്കോളെ.
both
പിടിച്ച് ശ്രമിച്ചേ.
sequences. 3.
ഇത് ഒന്നുകൂടി പൊക്കി പിടിച്ച് നിർത്താൻ
You
നോക്കിക്കേ.
can hold it for a transient movement.
ഒന്നുകൂടി നിർച്ചാ ഈ കാര്യം
Then any exercise will be good
അങ്ങനെ
3
പിടിച്ചോ.
to 3 plus.
പിടിച്ച് നിർത്തിയിരിക്കണം. ഇങ്ങനെ ഇരിക്കണം കാല്. ഇനി
Protectors
ചേർത്ത്
are also weak.
കാല് രണ്ട് ചേർത്ത് വെക്കണം. ഞാൻ അകത്താൻ സമ്മതിക്കരുത്. ചേർന്നിരിക്കണം. അകത്താൻ സമ്മതിക്കരുത്. എന്റെ കീഴിൽ തള്ളി പിടിച്ചേ, മടക്കി പിടിച്ചോ. ഈ കാല് അകത്തോട്ട് പിടിച്ചോണം. മടക്കി തന്നെ ഇരിക്കണം. അകത്തോട്ടിരിക്കണം. ഇത് മടക്കി വെച്ചേക്കണം.
The lower pressure plantar pressure also weak.
ഇത് മുകളിലോട്ട് വരണം.
Much better than what you find in the
ശരി വിട്ടെ. ചവിട്ടിക്ക് വെച്ചാൽ കയ്യിലോട്ട്
is able to flex.
ആഞ്ഞ് ചവിട്ട്.
Plantar
ആഞ്ഞ്
pressure is
ചവിട്ടിക്ക്.
good.
ചവിട്ടിക്ക്. ചവിട്ട്. ഇതും ചവിട്ട്. നല്ലപോലെ ചവിട്ടിക്കേ. ഇത് മുകളിലോട്ട് പിടിച്ച ഒന്നുകൂടെ.
Those also is weak, more weak than the plantar
മുകളിലോട്ട്
pressure.
എല്ലാം കൊടുക്കണ്ടേ? എല്ലാം പിടുത്തം എല്ലാം കഴിഞ്ഞു.
Reflexes, all reflexes were absent.
So diabetic 15 years.
Plantar was indefinite.
അച്ഛൻ കാലം അനക്കല്ലേ അച്ഛാ? ഇതെല്ലാം ഒരേപോലെയാണോ? വ്യത്യാസമുണ്ടോ എന്ന്
You got impaired sensation of distal part of the upper limb, somewhere around the mid forearm.
മുകളിലോട്ട് വരുമ്പോൾ നമ്പർ
Impaired pain both sides.
ആ വേദന വ്യത്യാസം വരുമ്പോൾ പറയണം. ഈ കുത്തുന്നതിന്റെ വ്യത്യാസം
He pointed with the pain
പറയണം.
There he was swaying, similarly which on the other side. There he
ശ്രദ്ധിച്ചിരുന്നു. ഇപ്പൊ
the lower limb it was extending up to the mid thigh. There he is telling. Okay.
ഇത് ശ്രദ്ധിച്ചിരുന്നു അച്ഛാ? ഇപ്പൊ ഉണ്ടോ?
The vibration is
ഇപ്പോഴോ?
impaired the upper and lower limb,
ഇപ്പോഴോ?
but mainly the lower limb. He makes occasional mistakes in the.
ഇപ്പോഴോ?
He made occasional mistakes in the upper limb, but that means it's impaired. But definitely impairment was seen in the lower limb.
ഇല്ല. ഇപ്പോഴോ? ഇപ്പൊ ഉണ്ട്.
Able to feel on the iliac crest,
ഇപ്പോഴേ? ഇപ്പൊ ഇല്ല.
but not able to feel over the knee.
ഇപ്പൊ എങ്ങനെ വെച്ചാ?
Joint sense was impaired in upper and lower limb.
അറിഞ്ഞൂടെന്ന് പറഞ്ഞാലും അച്ഛൻ ഒന്നുകൂടെ നോക്കിക്കേ. അത് തന്നെ. ഇപ്പോഴോ? ഞാൻ വല്ല അനക്കത്തില്ലേ ഇപ്പം? അനങ്ങീന്ന് തോന്നിയാൽ ഉടനെ പറയണം കേട്ടോ. ഞാൻ പറയണം.
It's the movement sensation also impaired in upper and lower limb.
ഇപ്പൊ അനക്കിയോ? അനങ്ങിയ ഉടൻ പറയണം കേട്ടോ അച്ഛാ. ഇപ്പൊ അനക്കുന്നില്ല, അനങ്ങുമ്പോ പറയണം.
He could not even feel that degree of movement. He could not feel on the angle also. He is not able to accept only large amplitude movement.
ശരി അച്ഛൻ നോക്ക് ചെയ്തോ കേട്ടത്.
Then he couldn't get any definite pseudotheoretic movements. He had bilateral ptosis, and he couldn't stand without support. He would tend to fall down because of severe postural impairment and weakness. So, an examination summarizing the finding: failures, yes, bilateral ptosis, which is not correctable. Extraocular movements were normal. Rest of the tailors were normal. Motor system, wasting and weakness of all small muscles of both upper limbs. Bilateral wasting of tibialis and tibia. Tone normal in the upper and lower limb. Power, shoulder, elbow, grade 5 bilaterally. Wrist flexion 4/5 right hand. Wrist exercises weak 2/5 on the right hand. almost normal on the left hand. Handgrip was weak bilaterally. Finger extensions were weak bilaterally, more on the right side. Finger flexors normal. All small muscles, thenar, hypothenar, were weak bilaterally. Mainly weakness was on the right side. That too for the finger extensions and small muscles of the hand. Lower limb, hip flexion, extension, abduction, adduction, about 3 by 5 on the right side, about 4 on the left side. Knee flexion 2 by 5 bilaterally, about 3 extension bilaterally. Dorsiflexion, plantar flexion about 4 to 4 plus. But main weakness was the dorsiflexion than the plantar flexion. All DT are absent. Pandas mute. Sensory in the upper limb, impaired sensation of pain, both hands up to the wrist. Vibration sense normal in the upper limb. He made, but when truly speaking, he made mistakes also in the upper limb. Impaired joint sense over both hands. The lower limb, sensory level up to mid thigh. Impaired vibration up to knee, Kuri up to the iliac crest. Joint sense impaired up to the ankles. So, where is your localization and what is the likely diagnosis? You want to see the findings once again? You can see most of the findings or summary are written. Any questions regarding the findings? I can clarify. Hello, anyone? Somebody can voice out. Otherwise, the interest of the case will be losing the interest in the case.
So peripheral nerves.
Yeah, that's the thing we also thought. Maybe peripheral nerve lesions, at least more peripheral because absent reflexes. Weakness only odd point is the lower limb proximal muscle is more weak than the distal muscles. But that can occur in radical neuropathic conditions like chronic CAD. So, agree with the diagnosis? I thought it could be a CADP. Agree with that?
Yes, sir.
Yeah. Any other thoughts? Anyone have any other thoughts?
Paraneoplastic.
Yeah, this is the etiology. And what at the moment we are talking about the site of lesion, we have to prove by investigation, then go for the other investigations.
Hello.
Yeah, tell me, yeah, please.
Sir, is he a diabetic, sir?
He's a diabetic. He's a diabetic.
A long-standing.
Yeah. What do you have in mind?
No, sir. The only odd point for a CDP is the slight asymmetry which is between throat.
No. Asymmetry can definitely occur in CADP. Say any acquired demyelination, if you look whatever CADP or AADP you have seen, how many of them are symmetrical? Most of them are asymmetrical. They start asymmetrically. There's nothing against asymmetry in today. I mean, don't diagnose an expert diagnosis of CADP or AADP because of asymmetry. In hereditary demyelinating disease, they are symmetrical, but acquired always they are asymmetrical.
Sir, one question, sir.
Yeah.
Sir, regarding the motor system, is the localization is radical, sir. But this bilateral ptosis, how to explain, sir?
Ptosis is most likely unrelated because he never noticed that. He never complained that. Probably because it's old age. Maybe they have been there for long.
Okay.
So CADP is a reasonable diagnosis. Okay. So
Yes, sir.
yeah. So investigations, blood chemistry was normal, LFT normal, serum calcium 10, hemoglobin HbA1c 7.1. CSF was done, which showed a protein of 194 and no cells, sugar 86. Then coming to the nerve context studies, there is decreased CMAP amplitude in all the nerves, median nerve, both right and left, right more than the left. Ulnar is normal on the right side, decreased on the left side CMAP. Peroneal is also decreased bilaterally. Tibial is also decreased. tubule is also decreased on both sides. So CMAP ambulate decreased all things. The conduction velocity was relatively normal. That's the point again. See, the velocity part is all normal. The amplitude is decreased. And the sensory order potentials were absent. In almost all the nerves except the right ulnar and left ulnar, the less affected nerves, they were absent. Otherwise, they are also absent. The FF latency is relatively normal. Okay. Now, what is the diagnosis?
Sir, only thing CSF albuminocytological dissociation cannot be explained with this axonal type of.
But an axonal type, you have to think of something called a CAAN. That is the classical CADP. You should get a emanating pattern. But here you find that the amplitude is very low, and the same time the velocity is normal. So in all the nerves, that means it cannot go with the CAD. There is an entity called chronic inflammatory axonal neuropathy. I think it's a very rare entity. That of course can explain all these things.
Can you explain the increased CSF protein, sir?
CAN. CAN also can produce elevated CSF protein, but more commonly in CAD.
So toxins.
The CAN problem is always a confusion. Some people, whether you can call it as a multifocal axonal motor neuropathy type or a CAN type, or somebody is always a confusion whether this entity exists or not. But we are not very sure about that entity, to be frank with you. That's why nobody talks about CAN. Even in the literature, is got a condition for CAN. In multifocal axonal neuropathy, CSF protein is normal.
So any alcohol use?
No alcohol use. Okay, and let us go further. The MRI was brought with the patient, which was taken in 2016, 2 years back. The MRI showed a disc prolapse at C6, C7 level here. And the lower the thoracic cord showed a long hyperintensity extending from, say, so the mid-thoracic level down up to the cornus epicornus region. Now, what do you think? Because I did not diagnose it, as I did not suspect a cord lesion. But luckily for me, the MRI was brought with the patient. That made me think. Then, when the NCV came, there was doubt about diagnosis. Why should it produce a normal velocity in the CADP patient? At the time, on the same day, more reflex were also absent. The absent reflex can be incidental because all diagnosed diabetes, old age, all reflex may be absent, even without any weakness. Now, what do you think? What do you want now? Is it a spinal cord tumor present for long duration, intramural radiation?
So the upper cervical, we are seeing the disc only.
Only disc only.
But lower down, there is an extensive more than 3 segments. Yes, sir.
Yeah, many segments.
Yes, sir. Many segments. So it could be a intramedullary. We have to see the axial, sir. Intramedullary lesion can produce this increased CSF proteins and can.
Intramedullary lesions without any block in the CSF path, they will not produce any CSF protein unless it's an inflammatory condition. But the inflammatory condition cells are not there. Only protein is elevated. If the protein has to be elevated without elevated cells, then you have to expect some kind of a Freund syndrome, where the intramedullary lesion is expanded to produce a block. But we don't see such a thing in this particular MRI. Let me see whether axial cuts are there. Another cut here. I don't know whether I don't have an axial cut, which shows only hyperdensity within the cord.
He had any bladder symptoms, sir? No.
No bladder symptoms. He did not come in bladder symptoms. Now, what do you want to do? With what possibility in mind will you proceed further? Does not it
Contrast.
contrast was the same. There was in fact the intramedullary tumor is a possibility one can consider because of the long duration, but there is no port expansion at anywhere. It's a long hyperdensity. There's no port expansion. And the say protein is elevated because and it can't. That's also a point against a tumor pressing on the subdural space. Unlikely for a demyelinating condition like NMO or anti-MOG because it's quite long duration.
Are there flowwards in,
Pardon?
yeah, are there flowwards in the posterior subarachnoid space?
Perfect, right. You are right, Wish. Now, if you look very carefully, the MRI is not that a good quality. Some suspicious there. No? So then this disc is totally unrelated, which cannot explain. The MRI brain was normal. Now you look at it more carefully. You can see some flavoids in the posterior part of the subarachnoid space. Here. The axial cut shows only hyperdensity. The contrast did not do not be contributing. Now you can little more carefully make out the flavoids in the posterior subarachnoid space, the thoracic region. And you can also make out the more clearly now with a zoom up view, the flavoids here. And spinal line just showed a dural AV fistula. Now in this picture, you have a repeat MRI showed clear flavoids now on the surface of the cord. This is how it appears. Unless you pay close attention to these flavoids, you will miss these flavoids. So that's the case. That is why the point again, remember, is that in dural AV fistula producing ischemic myelopathy, the weakness can be predominantly proximal. Need not necessarily be deep. In the myelopathy, what do you expect? You get the pyramidal lesion should produce distal muscle weakness or dorsal axis weakness more than the proximal muscles. Here, all the proximal muscles are more affected than the distal muscles. That is because that in ischemic myelopathy, it may affect predominantly the medial part of the. It does not respect a compression like a compression. It may affect the medial part of the pyramidal tract first, where the ischemia is occurring. So that can manifest the predominant proximal muscle weakness. Alternatively, you can explain that there may be a proximal involvement due to the proximal radiculopathy. But proximal radiculopathy also should produce weakness of the phantom. If it's LPSN producing hyperextensive weakness or abduction weakness, should have produced phantom flexor weakness also. So this is well known in. So whenever you get a proximal muscle weakness, tend to think about LMN lesion. But there are situations where you can have a ischemic myelopathy can produce a proximal weakness more than the distal. Okay, any questions in this case?
How do you explain the upper limb? Is it extending up as well?
It is extending up. As in fact, hyperdensity was not seen up to that level. And another point in dural AV fistula is that the fistula may be lower down. The ischemia manifests at even the upper level. That's also well known in AV fistulas. This is because the fistula's communication may supply the antispinal artery, which is the flow is retrograde in the lower part of the thoracic cord. It is not up down; it is down upward. So it can produce a compromised ischemia, can manifest many segments above the corresponding site of involvement of the dural AV fistula. That's another point which is also noticed in AV fistulas. The affection may be above the level of lesion. So probably that is the reason why you got upper limb involvement. The upper limb involvement is only up to D1, not above that.
So the axonal changes in the nerves, how can we explain from a spinal cord?
Yeah, that is because the affection of the anterior cells. It's got anterior cell ischemia is affecting the entire lung, no? That is affecting the anterior cells and can produce wasting and weakness. That is why the same permeability rate is decreased. And it may be, it need not necessarily be in the entity, but it can also be affect ischemic in any part of the cord.
So the CSF protein high is due to the
Most don't go to the myelopathy per se. Usually in ischemic myelopathy, CSF protein can be usually normal, but can be elevated. Can be elevated, 30% can be elevated. Whether it is due to the AV fistula itself is blocked in the subarachnoid space, but unlikely to the myelopathy per se, because that is ischemic myelopathy. That need not produce an inflammatory reaction in protein elevation there, but is described. Why it is elevated, I don't know. We can't explain. Probably because is it because some flow restriction, CSF flow restriction because of the fistula itself? I don't know. But it is described. Usually it is normal.
maybe CSF drainage is affected.
Yeah, exactly. Maybe its drainage is affected. Okay, any questions in this case? Okay, shall I go to the next one now?
Yes, sir.
Okay, yeah. Then this is a story of a 23-year-old female. It's a progressive deformity of the left little finger for 1 year. That is a complaint. And dropping of the left middle finger for the last 2 months. This is the only complaint by which she came. She had no pain, no sensory complaint. And I can show the video of the patient, the examination. Bone was power, biceps, triceps are all normal. In both upper limb. And you concentrate. Wrist extension was normal bilaterally. He has got a finger abduction on the left side. It's separated out, the so-called Wattenberg's and bilaterally normal. And also got a clawing on the little and index finger. No clawing on the middle two fingers. Why? Because the finger extensions of those two fingers are normal. The normal, he cannot extend the fingers. And it is better on the left index finger and the little finger, but maximum on the middle two. Extension support is as long as also is on the left side. Finger flexes were all normal. Checking the individual fingers again to find out there is a nerve distribution. But they're all equally and all normal. That's as well as long as on the right side, only the little finger was slightly weak. Abduction was weak. So his finger abduction was on the right side, all are affected. That's quite normal on the right. That's good for on the right side. That's where it is weak. That is good power. That's also why that is weak on the right side. That is weak on the right side. By trying again, when that right side came. Can't compare, left side is already weak, but compared to normal, I think it's slightly weak on the right side. Needs to be overcome since the policies loss. Common swipe is negative. That is normal. See, look at the little finger. That is definitely, that is weak. That the fourth palmar inversions is weak. Left side, everything is weak. All reflexive were absent. Sensors are all normal. Touch, pain, temperature, vibration, power, all normal.
ഇനി ഈ കുത്തുന്നതും ഇതും ഒരേപോലെ അറിയാമോ?
അറിയാം
ഈ രണ്ടും
അറിയാം.
കയ്യിൽ നിന്ന് മലത്തി വയ്ക്കാമോ? മലത്തി വയ്ക്കാം. ഈ കുത്തുന്നതും ഇതൊക്കെ ഒരേപോലെ
ഒരേപോലെ
വ്യത്യാസമില്ലല്ലോ.
ഇല്ല.
ഇത് അറിയാമോ?
അറിയാം.
ഇതോ?
അറിയുന്നുണ്ട്.
ഈ വിരല് താഴെയോ മുകളിലോ എന്ന് പറയണേ. അപ്പൊ എങ്ങനെയാ?
താഴെ
പിഴ
താഴെ
പിഴ
മേലെ
പിഴ
മേലെ
പിഴ
താഴെ
പിഴ
മേലെ
പിഴ.
മേലെ.
So sensors are all normal. These are the findings. But I want to concentrate on one particular finding that was going. The distal muscle look like
ഇങ്ങനെ
it's got the little fingers are out bilaterally, indicating the fourth palmar interest affect on the right side. Other interossei are normal on the right side. The other muscle affect on the right side is extensor pollicis longus and brevis. On the left side, the middle two fingers are dropping down, and the claw hand is seen only in the little finger and the index finger. Examination all interossei are very weak. The finger extensors are weak more on these two middle fingers and extensor pollicis longus. Okay, there is the clue I would like to tell in this patient. So an examination, wasting and weakness of all interossei of the left hand, weakness of finger extensors mainly of the left ring and middle fingers, weakness of extensor pollicis longus, rest of the muscles were normal. The right upper limb, weakness of extensor pollicis longus and brevis, and weakness of the fourth palmar interossei, all other interossei were normal. DTR all diminished or absent, sensibly normal. Where is your localization in this patient?
The absence of sensory symptoms and there is differential weakness. So anterior horn cells symptoms.
Yeah, perfectly right. You can have, in fact, a patchy involvement of the muscles there, the small muscles, and the finger extensor that would point to an anterior concept localization. Okay. Any other possibility you want to keep in mind? Any other possibility from anyone?
Pure motor syrinx, syringomyelia.
But there is absolutely pure motor syrinx affecting only anterior horn cells without any dissociative sensory loss and extensive reflex loss, not really the upper limb, but also the lower limbs are also absent without any affection in the lower limb. It's very odd for a syrinx sensation. Only confined mainly to that area, CH1 segment only. If it's a syrinx, we are postulating. Any other? Okay, one more, 1, 2, 3 points. Clue I'll tell you later on why, which is not fitting with anterior horn cell disease is that there are certain conditions. There's one condition. You know about the fascicular vulnerability nerve involvement. The fascicular vulnerability means that if a nerve is involved by some compression or anything else, need not get all the muscles separated by the nerve to be equally affected. For example, if ulnar nerve is compressed at the elbow, it can spare totally the medial part of the profundus and fascicular nerves. It may be confined to only the small muscles of the hand, mimicking an ulnar nerve involvement in the distal part. Similarly, if the conferral nerve is affected, it can natively spare the everters. It can only affect the dorsal and gates. The anti-introduction compression lesion can produce only involvement of the flexor pollicis longus. So there is something called fascicular vulnerability. In the early ulnar nerve palsy, the first muscle affected is the fourth palmar interossei. That is what is happening on the right hand. Little finger is going out. And in the radial involvement, it may not you expect a finger drop all through. No? The finger extensors are affected. Need not necessarily be. The index and the little finger has got additional extensors, like extensor indicis and extensor digiti minimi. So extensor digital involvement may preferentially or largely may affect the middle two fingers. So superficially, it may appear like a patchy involvement. We should make you suspect anticondylis is perfectly right. That should be a possibility, first possibility. but keep the possibility of a vascular vulnerability in a case of multifocal nerve involvement. So let us see one possible anti-Honsel disease like Rayama's disease. Then other is multifocal conduction block. Now, which do you prefer in this patient between these two possibilities? Because all the reflexes are absent in this patient. You don't expect absent reflexes in this patient of this age. I mean, there's no reason why it should be absent. So you should keep that possibility in the back of the mind. In a person with a relatively normal muscle but an absent reflexes, you should always keep the back the possibility of a conduction block. Anyway, that possibility you can keep in mind. Now, what test you need?
Nerve conduction studies.
Okay. Patient came with an MRI, which is normal. This is NC's report from the patient came with this nerve conduction study done on 11/9/2020. Conduction was normal. The sense that amplitude was all normal in the right median, left median, right ulnar. The intersecting nerves, the left ulnar and left radial, right radial, they are all normal. Velocity was normal. Proximal conduction was normal. The axial nerves are all normal. What do you want now? Snap normal.
CSF studies.
CSF, I did not do the CSF.
MRI.
MRI was done, came with the normal patient.
And it is inching study.
Yeah, repeated CV study. So it was done on before 2021. It showed, because we have strong suspicion of it, there must be some lesion there, either in the axon involvement or this will, or there should be a conduction block. Otherwise, patient not any weakness. Since already has got such a, if it's an axonopathy, definitely the amplitude should have come down before the weakness has set in. So the patient's got weakness since amplitude is normal means there must be lesion possible. Again, always keep this possibility in the back of the mind. In a person with weakness, not due to functional weakness or pyramidal weakness, if you had a normal CMF amplitude, the weakness is not due to an axonopathy. If there is axonopathy, the amplitude should be low before it is weakness. If we get a weakness and the amplitude is normal, always think of a proximal conduction block. If there is a conduction block, whether it's a root or somewhere, is there. Otherwise, you will not get weakness. So that's a principle in mind. So we take the repeat conduction. See, look at the CMAP amplitude. This is normal, but the proximally the EBS point is decreased. Sometimes EBS points can be spuriously below. We not take drop into consideration. Right median is also it is low compared to the distal. Left ulnar it is 6.2 and is grossly decreased in the EBS point. And the right ulnar is normal. So that shows that it's not a problem of a technical fault. If it's a technical fault, it should have been decreased on the other side also. But it only affected on the left side. That means it's unlikely to be a technical fault, more likely a genuine conduction block occurring proximally. This point is a very, very useful point. It just taught to me by Dr. Kimura. He said that when you get a normal CMAP amplitude weakness, it is conduction block. Straightforward one sentence. The right radial is again normal. Left radial is got a conduction block again at that point 2.9. And the other muscles are normal. So snaps normal. So what do you want now? What is the likely diagnosis now?
Demyelinating.
Yeah, multifocal motor
Radical.
neuropathy with conduction block. So what else?
Anti-GM1 antibodies.
Yeah,
Anti-GM1 antibodies.
so anti-ganglioside antibodies were done negative. Then what do you want to do now? You want to treat or not treat? Treatment means you have to give IVH.
Treat, sir, IVH.
Treat. Okay. Right. You are sure? Okay. I'm sure. So I got that. Then you find out what is the value of these antibodies and multiple conduction law. Does a normal antibody try to rule out MHCV? That's the question comes to your mind. Most studies report elevated titers of anti-GM antibodies in 50% of the patients with multifocal motor neuropathy, but the values and sensitivities depend upon the methodology. Very high titers of anti-GM antibodies, that is 1 in 6,400, have 80% specificity, but only 20 to 30% patients MMN have titers of 1 in 1800. Lower values than 1 into 400 or 1 is to 800 are less specific and can be found even with other neuropathies and including ALS. Clinically, these MMN patients with heavy titers antibodies are typically indistinguishable from patients with negative titers. So this titer may not be positive or antibody may not be positive all the time, only in 50%. Then CSF not done, because why CSF is not done? Because CSF in MHCV, findings are usually normal in MHCV, or even only mild elevated protein content. So it may not be very useful to diagnose MHCV in CSF. So for the patient IVAG, given 2 courses, one interval given. This is after 2. That is the finger drop is disappeared. Look at the finger drop because earlier it is not there. You want to see the very beginning. Finger drop is disappeared. Our state is still better. Right side anyway it is better initially. That is also slightly better than before. But the EHL on the right side did not improve. That remained the same. But EHL extensive policy. That remained weak without any improvement. That is same as before. This is also all remain the same. The improvement was seen in the finger abductor as well as the finger extender. Most of the findings normal. Now repeat conduction was done on 22 months later after the IVHC. Again showing the conduction block in the amplitude. What is more important is you have to compare with the previous values. Just finding conduction block does not mean anything. Also you can find the after conduction block here. Presents a conduction normal. If you have latency left ulnar is normal, other is normal. Now compare with the previous and the recent conduction. This is done on 2 months back. This is done recently. On the right side is recently. Left median, if you take the amplitude has come up, but the conduction block remains. It is really better now compared to the initially. It was at 0.2 and it is 15.4. Now go to the next value. And ulnar now on the right side, on the left side, it was 6.2. It was little come down a little bit. It almost remained the same, not much of a difference. Come to the radial, it was worsened. Initially, it was 5.3. Now the amplitude has become 3.6. So as far as after treatment, some of the nerves has improved. The right radial is worsened, left ulnar and left ulnar is improved, but left radial remains the same. Left median has improved. Sorry, left median and ulnar has improved. Improved. Left ulnar remains almost the same. Left radial, so not left radial, right radial is worsened. So what will you do now? continue IVIG because it takes long time for the improvement to occur. But the problem in giving IVIG is what? Cost. Every month or every 2 months, you have to give 1 to 2 gram per kg body weight means it's a hell of a lot of money. Unless you have insurance, it's going to be a problem. So I suggested rituximab for the patient. She said she's completed family and come forward. Till that time, she will continue to take IVH, monthly IVH. So any other questions in this case? Any questions? So the point I want to tell you again that remember the possibility of a fascicular vulnerability in a suspected case of an anticonvulsant disease. This I have myself made a mistake where I initially thought anticonvulsant disease turned out to be something mistaken wrong because of the selective patchy involvement mimicking an anticonvulsant disease. Another thing is an anticonvulsant disease, by the time it produces weakness, invariably there will be wasting. Because unless and until more than 50% of muscle fibers are lost, you will not get weakness. So in anticonvulsant disease, if you find no weakness, no wasting, but weakness, it should be acute involvement. A chronic involvement invariably will have wasting. Because 50% muscle fiber loss, wasting muscle bulk will loss 50%. Still power may be normal. So by the time they got anticonvulsant produce weakness, that wasting should be there in a chronic case. So that's another point against this particular girl who did not have wasting, only significant weakness.
And there is global reflexia.
The global reflexia, it's an additional point, but not absolute because we do not know the reflex status area. Many individuals have a global reflexia by themselves, but it's not very common in a young person like this. What you said is correct. But if the lower limb muscles are also affected to some extent, reflexor absent, I would have happy to call it as very highly significant. Some degree of involvement of muscle weakness and absent reflexes, but the conduction wall is all normal in the lower limb, so the absent reflexes cannot become much significant. Any other questions? So, okay, we'll go to another patient now. 64-year-old diabetic. Yeah, please come. Please.
Sir, even if the conduction, there is proximal conduction block that can produce areflexia.
They can produce areflexia, correct?
Okay,
But the conduction also produce weakness also.
Okay, sir. But then this proximal in the lower limb we cannot explain, sir.
Yeah, that's the point. That's the point. Lower limb we can't explain. If there's some weakness is there, I would have been happy to call it as significant.
Yes.
Because to produce weakness, demyelination per se will not produce weakness. Any degree of demyelination will not produce weakness unless there is a conduction block. That means CMAP amplitude should come down either by axonopathy or either by conduction block to produce weakness. The only clinical phenomenon due to demyelination is you may get sometimes absent reflex suppose can occur because that requires a fast conduction, or sometimes vibration can be impaired because vibration also depends upon the fast conduction of the impulses. Vibration is nothing but touch fibers going at a very fast frequency. The fast condition affected, that may be impaired. Otherwise, pain sensation, test sensation, everything will be normal if the pathology is only demyelination.
Yes, sir. Like in Miller-Fisher,
Like in Miller-Fisher, correct. Okay, shall we go to the next one? This patient came with diplopia on looking to the left side. It is binocular. The image is separated horizontally and vertically between the left side. There was no pain. On examination, the quick examination, I did not find any abnormality in the ocular movement. Apparently, there was some restriction on looking to the left side. Again, I myself was not convinced. So I considered maybe an early left succinar palsy, but again, the one disturbing factor was that he was complaining of some vertical separation also. Then I was about to send him, asked him to come for follow-up. Then he showed me a paper and told me this is how he saw the images. The one on the left side is this car number plate, which is seen like this. And second is the tube light, which is seen like this. What is your diagnosis? Anyone? This picture he himself has drawn and showed me. That made easy for my diagnosis. It made it easy for my diagnosis. No opinion, anyone?
Be oblique is also
Which side?
right side.
Perfect. Yeah, you're right. I'll tell you, what will you do in order to confirm it? I'll tell you what the reason. So you do the Milky's head rotation.
ഇനി ഇപ്പം രണ്ടായിട്ട് കാണുകയല്ലേ
Ask you to point and pick the where it is double.
നോക്കിക്കൊണ്ടിരുന്നിട്ട് ഞാൻ തല രണ്ടായിട്ട് കാണാൻ കൂടുകയോ കുറയോ ചെയ്യുന്നത്
Asking in which direction is becoming more.
ഇപ്പം തിരിച്ച് തലം കൂടി തിരിച്ചു ഇപ്പോഴേ
It says one.
ഇപ്പോഴേ
It says two.
കൂടി വരുന്നു കൂടി വരുന്നു വെർട്ടിക്കൽ സെപ്പറേഷൻ കൂടുന്നുണ്ട്.
Separation is more. I'm seeing two. So what does it mean? What is this test called as? The Milky's head rotation test. When he turns the head to the right side, or rotates head to the right side, the diplopia increases. On return to the left side, there is no diplopia, the diplopia disappears. So what is operating here is on turning to the right side, which are the right eye intorts, the left eye extorts. Okay. The intorts of the right eye are which are the one superior oblique and superior rectus. If one of them is weak, what will happen? The eye will not intort properly, then separation will be more, they will not properly, and the separation will be more. One will not be put into action. If on the other hand, left side muscles are affected, nothing will happen because it is the extortus which is put into action. Okay, so this is a test shows us got a positivity. Right superior oblique is weak on this patient. If the rotation was to the left side, it should have been the left superior oblique. But the easiest thing is that the torsional diplopia, which results from ocular cyclotorsion, occurs in fourth-line palsy. This condition can be quickly assessed by having the patient with a horizontal straight line, such as edge of the floor. A patient's cyclotorsion from unilateral fourth-line palsy will see a horizontal line and a second tilted time either above or below it, intersecting the side of the affected eye. This is how the patient will see. Here you can see that there is one horizontal line, that is a normal image. This is how you see the second image in the case of a right superior oblique palsy. This image is tilted and pointing toward it, form an arrow like this. The direction of the arrow points to the side of the fourth nerve palsy. If the arrow is to the right side, that means it's right fourth nerve palsy. Here the arrow is to the left side, it is the left fourth nerve palsy. This is a very simple thing to remember. When you have difficulty in finding or do this test and all, ask the patient to draw on a piece of paper how he sees images. He will draw like this, you can find that side is affected. Testing ocular movement, looking for the vertical restriction, downward restriction, the rectal position, or sometimes very difficult in a mild superior oblique palsy, which you will feel when you start seeing your patients. It's good in theory, but practically very difficult to find the vertical separation. But this is a very simple bedside technique. Yeah. Any questions? I think you have understood why separation is occurring and not. If you have not understood, tell me, I can explain it once again. Why this is rotated? See, like this, because on the right side, like imagine you have got a right superior oblique palsy. When the right superior oblique palsy is there, which is an indautor, okay. When the indautor is weak, eye goes into extorsion on the right. Think only or imagine your right eye, your right superior oblique is weak, okay. That eye is seeing, eye is actually has gone into extorsion because the indautor is weak. Extorters are normal. When the eye is extorted, the line which you see seems to be indauted because the perceived image is to the opposite of ear rotation. Okay, what you perceive is opposite to what your rotation. What the point? So when the eye is rotated, you see the image internally rotated. I mean, rotated other way around. It will be a counterclockwise rotation. Your globe is rotating to the right side, the image will be rotating to the left side. That's how you all see all the images. Okay, whatever faults the retina is opposite to what is seen in the say outside. That is the second image is rotated inside or down, or so-called indaution of that image, and forms an arrow to the right side. Is it clear to you now? I'm not hearing an answer from anyone. Is it clear?
Yes, sir.
Yes, sir.
Okay.
Yes, yes, clear.
Okay, right. Now I'll go to the another case. This is a 40-year-old lady. Short is again a short case.
The cause of the other patient, diabetic.
Diabetic. A 40-year-old lady noticed numbness and clumsiness of both hands for the last 10 days. The clumsiness was in the form of difficulty in turning the key. I think for the histories in Malayalam, it's a short history. 1 week.
ഇവിടെ തുടങ്ങിയാൽ മതി. രണ്ട് പത്തിക്കും ഇവിടെ എന്തോ
തുടങ്ങി ഈ രണ്ട് താക്കോലെടുത്ത് തുറക്കാൻ നോക്കിയപ്പോൾ ഇവിടെ ഞാൻ ബലം പ്രയോഗിക്കാൻ പറ്റുന്നില്ല. അപ്പോഴാണ് എനിക്ക് അനുഭവപ്പെട്ടത്.
ഈ പെരുപ്പ് എന്ന് വെച്ചാൽ പിരിവിരിപ്പാണ്,
പിരിവിരിപ്പുമാണ്, ബലക്കുറവും ഉണ്ട്.
രണ്ട് കൈക്കുണ്ട്. ഒരാഴ്ച മുമ്പ് തുടങ്ങി. ഒരാഴ്ച 10 ദിവസം, ഒരാഴ്ച മുമ്പ്. ഓക്കെ. ഇതിന് പെരുപ്പല്ലാതെ വേറെ എന്തൊക്കെ വിഷമമുണ്ട്? പെരുപ്പും ബലക്കുറവും അല്ലാതെ വേറെ കുഴപ്പമൊന്നുമില്ല. ശരി.
So she's telling perip in Malayalam means numbness and difficulty in opening the door with the key. She only come to the right side because she's not using the left hand for opening the key. But numbness was there on both hands. This is the story of the patient. Now examination.
ഞാൻ പറഞ്ഞ പോലെ ചെയ്യണം കേട്ടോ. ഇത് പൊക്കിക്കാൻ മുകളിലോട്ട്, ഇതും പൊക്കിക്കാൻ.
Metropolis is normal.
തലവരുടെ കുഞ്ഞുങ്ങളോട് ഇങ്ങനെ പിടിച്ചേ.
Opponents is normal.
ഇത് പിടിച്ചേമ്മ. ഇനി വേറെ അകത്തി പിടിക്കും. അകത്തി പിടിച്ചേ. പിടിച്ചോണ്ടിരിക്കണം. അകത്തോട്ട് പിടിച്ചോണ്ടിരിക്കും.
The right side.
ഇത് പിടിച്ചേ. ഇത് പിടിച്ചേ.
That's also weak bilaterally.
ഇത് പിടിച്ചേ.
But conducted digitiminity was normal.
വലിയ കുഴപ്പമില്ല. ഇത് തള്ളിക്ക്.
That's also good for her. Conducted digitiminity.
ഇതാ. ഇനി വേറെ മടക്കമ്മ. നൂത്തെ.
Indroche were weak.
മടക്കിക്ക്. നൂത്തെ.
Over the left side.
ഇത്.
All weak bilaterally.
ഇത്. ഇങ്ങനെ പിടിച്ച ഈ പേപ്പർ ഇങ്ങനെ പിടിച്ചോ. ഒരാ സമയക്കല്ലേ.
Correction was weak bilateral.
പറ്റുന്നില്ല. നോക്കട്ടെ. പറ്റുന്നില്ല. ശരി.
So I think I'll show the finding once again for condition's sake. Affected digitiminity was weak. So it was normal. But FT was weak. Ingressions, I mean, crochet and umbilicus were weak. And adductor policy was weak. So he has got bilateral weakness of all introchet and adductor pollicis. Normal thenar muscles, normal abducted digiti minimi and opponents. Rest of the muscles normal. DT are all normal. Sensory system normal. What is the diagnosis?
How is the finger flexor reflexor? Sorry, sir.
Reflexes are all normal. I did not show that it was normal, and that did not show. Sensory also did not show. It was to save the time, I did not show.
Sir, is it deep branch of ulnar on both sides?
Both sides, okay. That's a good possibility. Any other possibility? But how did you combine a paresthesia with both hands?
Could it be a
Yeah.
cervical myelopathy lesion causing?
Cervical rib is another possibility which can produce this thing. Okay. Can produce paresthesia. Deep branch of ulnar is a possibility, but paresthesia she's combining, but there is also sensory loss. So it's a possibility. Cervical rib is another possibility which can happen. Usually the cervical rib, the first muscle affected is the thenar muscle. That is a DDF carpal tunnel syndrome. Because it is compressing, the D1 root is compressed with the cervical rib. Okay, the D1, the muscle solely separated with the D1.
Cervical myelopathy.
Pardon?
Cervical myelopathy. CAT1.
You mean say anticondylar disease separated the CAD1. Yeah, inside inside the core, it's a possibility which you can. Okay. Right. Now what do you want now? Conduction?
Nerve
Yes.
condition still.
Okay. Conduction, I will check conduction. Normal. Right ulnar conduction normal. Left median, right left ulnar conduction normal. Other condition, sensory conduction normal. Now what do you want? You want MRI?
Yes, sir.
MRI cervical.
Yes, sir.
Yeah.
Action from FDI.
Yeah, exactly. That's the thing you wanted. Because right median CMAP normal, right ulnar CMAP normal, right snap normal. So both conductions are normal. Now you'll always pick up from the FDA. So I'll tell you what Uma said is correct. But what is the clue you ought to tell? What made you suspect it is a deep branch of ulnar? It's unusual for a deep branch of ulnar to simultaneously bilateral.
While learning
The
bicycle or
abductor DT minima is slightly better.
Yeah, that's the point. The abducted digitae minimi, the hypothenar muscle is spared, but the introtia and adductor pollicis is closely affected. That's the point. That shows that the lesion is in the distal, the Guyon's canal distal part, in the deep branch of ulnar. After exiting the supply of the superficial inhibition, which supplies the hypothenar muscles and the sensor. It can sensory also be affected. The most part of the Guyon's canal is affected. So always in such a case, pick up from the MDI. So the amplitude, see the amplitude of the pick up from the MDI, it has grossly decreased compared to this ulnar nerve. And the latency from the wrist to ADM was 2.5. Latency the wrist to FDA was 4.8. The amplitude is low compared. That's the normal latency from the electron. So this is again from the right FT and ADM. This is from the ADM. This is from the FT amplitude. Again, the latency is 4.8. Then this is the distal mode latency is less than 4.5 is the value. When comparing with this one, it should be less than 0.2. Here it is more than 0.2. More than 0.2, 2.5, 4.8. The amplitude is low. So it's bilateral, deep range of ulnar nerve involvement. What is likely etiology?
He must have practiced riding bike or something.
Yeah, correct. Perfectly right. The patient was already took 5 to 2 weeks. He started learning scooter Honda Activa for the first time and undergone 3 to 2 hours of training on the day prior to the onset of symptom. And these are the situations where the deep branch of pulmonary is likely to be affected. The handle of the pliers may touching on the Gowans canal or maybe holding the handle for a long period of time. I think I had shown this case earlier to you from the Milliard meeting. So what is Gowans canal? Is a tunnel formed by the transverse carpal pisicohamic ligament, tendon of the flexor carpi ulnaris muscle, and pisicohamic bone. The tunnel contains the palmar branch of the ulna. Palmar branch divides into superficial and deep palmar branches that passes the tunnel. So this again, I'll show you this one. This is the tunnel. This a deep branch goes like this, superficial branch goes like this. And let us show the other diagram, which will be easy to understand. The superficial division of the palmar branch innervates the palmaris brevis muscle, palmar 5th digit, and ulnar aspect of the 4th digit. Then the deep branch innervates hypothenar muscles here. The proximal part supplies hypothenar. The two most arterial umbilicals, the introshi, adductor pollicis, and deep flexor pollicis brevis. Let us see, this is how the Gowans canal, this is the picture of the Gowans canal. This branch supplies hypothenar muscles. This is superficial sensory division. This is the deep branch. Okay. This is the palmar cutaneous division branch. So the region happens to be at this region, distal to the Gowans canal, where our patient had. It affects all muscles supplied deep branch of the motor branch, except the hypothenar muscle, and the sensory branch is not affected. This is a sensory branch which is fired. This is the branch of the hypothenar which is fired, as in our patient. The region happens to be at this level, proximal deep palmar motor region, affects all ulnar-innervated hand muscles, including the hypothenar muscles, but sensory is not affected. The region is here, affects all branches of the ulnar nerve, including proximal, distal, deep palmar, and motor sensory branches. This happens to be only in the sensory division, that is not in the Gowans canal, only superficial forms part affects only the sensory branch, but sprays all motor fibers. So depending upon where the compression is, in the Gowans canal, you can have sensory involvement in the ulnar nerve, you can have hypothenar involvement, you can have deep branch involvement. Or sensory may be spared, it can have hypothenar and deep branch. Or hypothenar and sensory may be spared, only be confined to the deep branch as in our patient. Okay. Shall we stop here? I think one more. Time for one more case, okay?
In that patient with dural fistula, would you have done an MRI if the patient had not brought the MRI?
Yeah, definitely I would have done the MRI. No, the first time when he came to me, because my clinical diagnosis was not dural fistula or a myelopathy at all. I was suspecting only CADP or that as my clinical diagnosis. When the nerve conduction study came and shows no demyelination, then we have to think of a primarily an axonopathy-like condition, like a CAAP. And the protein became high. So that was again a controversial statement. But I was not making an myelopathy. Luckily, the patient brought an MRI with him. That made my diagnosis easy.
Now, would you have done an MRI if the patient had not brought the MRI?
If you ask me, I don't know whether I would have done it or not. What else can I do? Because I am stuck with the diagnosis. The protein is elevated means there must be some problem inside the dura. In that sense, I may do an MRI without having a diagnosis in my mind. Anyway, he has got some lesion, weakness is there. He's got a protein elevation. That means some pathology inside the spinal cord and the spinal roots. This one has to be inflamed. So I may take an MRI in that sense with contrast.
If the CSF protein was normal, he could have.
No, I wouldn't have done that.
Yeah.
I wouldn't have done that. I would have missed the diagnosis.
Yes.
Diabetes also can cause elevation of protein.
Yeah, but see, all said and done, in diabetes, hardly ever it goes above 150. Maximum 150 is the one, CSF protein is the one which is say maximum we can occur in diabetic radicular neuropathies.
But here it is only 194.
194. But again, is that you have to corroborate with the clinical picture. This is not the picture of a diabetic neuropathy or a diabetic flexopathy. It affecting both proximal and distal, so both upper and lower limbs. This is not a pattern of diabetic involvement. And the duration is progressive, gradually progressive over months. So that's not like a picture of a diabetic flexor radical. You have to take everything into consideration and then come to it. Shall we stop or go for one more case?
One more case.
A 50-year-old man presented with history of numbness of the left palm. Just 1 minute. Okay. So I only want 5 minutes more. I got another meeting at 10:30. I think I'll do it next time. It's a long case. Okay. So
Short case.
Short case. I will be missing another short. Long case. No, I think for just for completion, I'll show this particular video to show the three-step test, because I'm not. They're not for you people, for the juniors. This is how you do that. So looking straight again, you find the head is tilted to the left side. You know, right? Head is tilted to the left side, indicating that what. It may be a lesion on the respiratory palsy on the right side. So before you do the test, make the head straight. Okay. So look now. You look now. The right eye is up, left eye is down. Okay. That means what? The depressors the right eye is affected, or elevators the left eye is affected. The depressors the right eye are right superior oblique and right inferior rectus. The elevators the left eye are left superior rectus and left inferior oblique. Correct? So now he has got 4 muscles are at fault, can be at fault. Left elevators or right depressors. So right depressors 2, left elevators 2. This is the step 1. Now ask the people to look to right and left to find out which direction is more.
The first step is 3 steps test. First step is which eye is up or down. The right eye is up and or left eye is down. That means the depressors of the right eye is weak, or the elevators of the left eye is weak. The depressors of the right eye are superior oblique and inferior rectus. The elevators of the left side are superior rectus and inferior oblique. So we have got 4 muscles are weak now. Either these 4 muscles we have already mentioned. Now you want to look is in which direction the vertical separation is more. You don't know here or on this side.
So you find the separation is more central.
In which direction the vertical separation on this side. Obviously this is more.
See, vertical separation is more on looking to the left side, not on the right side. I will show that subsequent video. So if that is a situation, as you can see, obviously this left separation is more. So which muscles out of the 4 will be weak? Which muscles will be weak? That means left eye is down. That means it could be left superior rectus or right eye is up, right superior oblique. Correct?
Yes.
Yeah, so it may be left superior rectus or right superior oblique because there is a vertical discontinuity. We don't know which eye is at fault. It may be right eye, it may be left eye. Left eye is fault, left superior rectus. If right eye is fault, right superior. So these are the two muscles now at fault. That's the
It will
second
be
step.
separated more on this side, so rather than here. Here also is separated, but much more separated here. Okay, correct? Yes. Okay. So this means this means that which other muscles could be weak? That means the right superior oblique is weak or left superior rectus is weak. Because left superior rectus is weak, the right eye is down. Or right superior oblique is weak, right eye is up. So either right superior oblique is weak or the left superior rectus is weak. Okay. Now what you do, the three step, this second step is over. You turn, rotate, you rotate, show the things. Okay. Show the turn the head, the is more or less. It is increasing.
Now the vertical separation is less on turning to the left side. See, the separation disappeared, but on turning to the right side,
turning to the left side, the vertical discontinuity is less.
on turning to the right side, it is more. That means when you tilt the head to the right side, as already told, the interrogators the right side are affected. Turning the left side, left interrogators will be affected. Here, right interrogators are put into action, left extrorotors are put into action. Let us see that here diplopia is more. That means if the right superior oblique had been weak, out of the two interrotors, only one interrogator is acting on the right side, that is superior rectus. Superior oblique is paralyzed. So superior, what is action superior rectus? It elevates. Normally, when both contract, superior rectus and superior oblique contract, as interrotors, one is an elevator, one is a depressor. There is no vertical movement. Here, superior oblique is affected, which is a depressor. Only superior rectus act as an interrogator, which elevates the eye. Already the right eye is up. Now, in putting it in this position, if the superior rectus alone is put into action, the right eye elevates. So the vertical discontinuity will be more and the diplopia will be more. If the left superior rectus had been at fault, on turning to the right side, nothing will happen. Because in this position, superior rectus on the left side is an interrogator. That is not put into action. Only the extrorotors are acting on this position on the left eye. So nothing will happen. And if you put turn to the right side, if the left superior rectus had been weak. Okay. Now turning to this side, what happened means if right superior oblique is in this position, the right superior oblique is weak, nothing would happen because right eye is extorting in this position. The superior oblique is not extorted. Okay. So that's the Milky's three-test test. Okay. I think you have understood it. So we'll call it a day. Thank you for patient listening. Okay, next time.
Thank you, sir.
Yeah.
Yes, sir. Thank you very much.
Next time also 9 a.m. Eh? Yes,
Okay, sir.
Okay.
Thank you, sir.
Thank you. Bye. Good night.
Thank you, sir.
Thank you. Thank you. Good time.